Hello everyone. So welcome to the lecture on approach to renal disorders. So I hope you have watched the videos of symptomatology and assessment methods in renal disorder. Once you have those basics very clear in your mind, we are just going to need to apply that knowledge of those two lectures into the present lecture so that we can practically create an algorithm for diagnosis of renal disorders, right? So the first step, when the patient comes to you with the renal disorder, what do we do? When the patient comes to you with the renal disease, when I say renal disease, I have removed the word suspected. That means the patient has abnormal creatinine. How do we proceed? The first step is to differentiate. The first step, when a person comes with renal disease, the first step is to differentiate whether the patient is suffering from acute kidney injury or whether the patient is having chronic kidney disease. Is the first step I want you to do. Whether it is MCQ or practice, our steps remain the same to differentiate whether the patient has suffering from acute kidney injury or whether the patient is having a chronic kidney injury. We will be writing the reasons why this is our first step, but let's understand it first. The first step is to differentiate between acute and chronic, because that changes the whole approach to treatment. If a person is suffering from acute kidney injury, the patient is likely to require prompt, proactive evaluation and treatment to prevent the complications of the disease and to ensure complete recovery. That means the patient may need to be hospitalized. But when you look at the chronic kidney disease means the duration of the disease is already more than 3 months. So unless there is a serious manifestation, most patients of CKD can be managed on outpatient department. So there is a different approach when you come to the management of the disease. So when we say a patient has come to you with a elevated creatinine or a elevated cystatin C, you know that there is a renal problem. But before you enter into what is the problem, first you divide them into group, whether this is an acute problem or it is a chronic problem. So how do we do that? Let us take into account the following parameters that we have discussed in our previous lectures. So the parameters, the most important parameter we have discussed in the assessment method is the corticomedullary differentiation on the ultrasound. Most important parameter is the corticomedullary differentiation on the ultrasound. You can also take the help of the size of the kidneys on the ultrasound to help differentiate between whether you are dealing with a case of acute or chronic kidney disease. You can take into account the urine osmolarity, the urinary cast also. So you can take into account the presence of cast in the urine can give you some clue to the probable diagnosis. You can compare the urine and the plasma osmolarity. You can compare the urine and the plasma osmolarity to identify probable cause. And you can take into account the presence of anemia and the metabolic bone disease. We can take into the picture the presence of anemia and the presence of metabolic bone disease. So I hope you have watched the video of both the anemia and metabolic bone disease Of course, they are part of one video lecture only. But if you have not watched them, maybe you could watch them before you come back to this approach table. So when we need all these parameters together, will help us differentiate whether it is an acute disease or a chronic disease. Take it forward, please. If the patient is a case of acute kidney disease, as discussed, the CMD will be normal or preserved. The CMD will be normal or preserved. The size of the kidney will be normal or enlarged. In acute, there is inflammation. The cast, most common cast present in the acute kidney disease is the hyaline cast. When you compare the plasma and urine osmolarity, it is either concentrated or dilute depending on the cause. So whether if it is pre-renal, we know that it is concentrated, and if it is renal tubulo-interstitial disease, it is going to be dilute polyuria, but never the same. The anemia is uncommon. It is uncommon in acute kidney disease, and the metabolic bone disease never present. So it takes minimum 6 months of renal failure for metabolic bone disease to occur. So in acute disease, you will never have metabolic bone disease. But when you compare the CKD, or should we first do the acute kidney disease first? Let's complete that. So a patient walks into your clinic, and based on the parameter you see that the ultrasound is normal, I'll say CMD normal, size normal, cast is also most benign, the hemoglobin is normal, and the bone disease is absent. So when everything looks normal, you must suspect that it is acute kidney injury. But none of these findings are specific for the diagnosis. They are as good as normal. None of them are specific for the diagnosis. So in a patient with acute kidney disease suspected, you need to use the KD-IGO criteria. So that is the kidney diseases improving global outcome. Improving the global outcome criteria. The guidelines, the KD-IGO guidelines is what you are going to use to confirm the diagnosis of the acute kidney injury. So you want any one of the criteria, to be positive for confirmation of the disease. So you saw that the patient has elevated creatinine, but the sonography, the hemoglobin, the bone health is normal. So you feel that this may be an acute problem. But to confirm that it is an acute problem, you want the patient to satisfy any one of the KD-IGO criteria for the diagnosis of acute kidney injury. So what are they? Number 1, if the urine output is less than 0.5 ml per kg per hour for minimum 6 or more consecutive hours. So in an acute kidney disease, you can monitor the hourly urine output. If the urine output remains consistently low for more than 6 hours, you can say that it is a acute kidney injury. Or if there is a rise in the serum creatinine by more than 0.3 milligram from the baseline within a period of 48 hours, or there is a rise in serum creatinine by more than 1.5 times the baseline within a period of 7 days. Using any one of these criteria, you can mark for sure that the patient is having acute kidney disease. So when a patient has got any one of these features, you can confirm the diagnosis that the patient is having acute kidney injury. Now let's compare with the chronic side. Compare with the chronic side. In CKD, what will you find? The CMD may be normal or lost. If it is lost, it is definitely CKD. Size of the kidney may be normal or shrunken. If it is shrunken, it is definitely CKD, because there is no case of acute kidney disease which come with shrunken kidney. The cast in the urine, the specific cast is the broad waxy cast, which can be seen only in advanced cases of chronic kidney disease. The damage to the tubule is so severe that the tubule can neither dilute nor concentrate the urine. Neither dilute or concentrate the urine. So the plasma osmolarity becomes equal to the urine osmolarity. This is called as isothinuria. Isothinuria is specific for diagnosis of CKD. Anemia, occurrence of anemia is a common but non-specific. The metabolic bone disease, if present, is specific of the disease. It may not be present in all cases of CKD, but if the bone disease is present, you know that the duration is more than 6 months. That means obviously the patient is having chronic kidney disease. You can say that. To confirm the diagnosis, by definition, ideally you need documented renal disease. You need a documented history of renal disease for more than 3 or more months duration. So to confirm the diagnosis, ideally you need to have a medical record. But India hai boss, medical records are uncommon in our country. So what is the alternative approach? If the presence of, by the presence of one or more of the specific features, one of the more of the specific parameters enlisted above, mentioned above in the table, those with the asterisk mark. So if a patient has got any one of the specific characters, specific character will include loss of CMD, shrunken kidney, broad waxy cast, isothinuria or metabolic bone disease. So along with elevated creatinine, if the patient has any one of those, you can still classify them as suffering from chronic kidney disease. You can classify them as suffering from chronic kidney disease. So simple. So in practice and MCQ, first step is to differentiate whether the disease is acute or chronic. As I told you, why to differentiate? Because in the management should be prompt and proactive. It should be prompt and proactive. Most probably you will have to admit the patient of acute kidney injury. Why should it be prompt and proactive? To prevent the complication. To prevent the complications and to ensure complete recovery. That's the word you have to use. And to ensure complete recovery. Otherwise, some damage may become permanent. So, in a case of acute kidney injury, the speed of evaluation needs to be rapid. You don't want to tell them कल टेस्ट करा के परसों आना, 1 week के बाद आना. No, you want to admit the patient identify the cause and treat the cause so that you can prevent the complication and ensure complete recovery. However, the chronic, unless having any serious, that is life-threatening manifestation is present, unless a serious life-threatening manifestation is present, you can do OPD management. Outpatient management can be prescribed to the patient of chronic kidney disease. So it's a very practical approach that we have to keep when we talk of approach to renal disorders. So even in the MCQ, I am going to see whether the patient is having acute kidney disease or chronic kidney disease, because my choice of management will be different. How do I classify further? The acute kidney disease can be divided into 3 groups, need to be further classified into 3 groups. I have to divide them into. So the 3 causes of acute kidney injury can be pre-renal causes, it can be pre-renal causes, it can be renal cause of ACII, can be renal cause of ACII, or it can be post-renal ACII, can be post-renal ACII. So after confirming acute kidney injury, I want to evaluate further to identify if the patient is having pre-renal, renal or post-renal ACII. Among the 3, most common is the pre-renal. Most common, almost 85% of the cases is going to be pre-renal, and least common is the post-renal, because only 1 to 5% cases are going to be post-renal. If the patient happens to be renal, I will require further evaluation. I will require further evaluation to differentiate whether the patient is having tubulo-interstitial disorder or the patient is suffering from glomerulonephritis. Tubulo-interstitial disorder or the patient is suffering from glomerulonephritis. I will have to evaluate further. Among the 2, which is more common? Tubulo-interstitial disease is more common. 94 to 96% of the cases is going to be tubulo-interstitial disorder. Please remember, glomerulonephritis constitutes only 4 to 6% of the cases. Constitutes only 4 to 6% of the cases. However, it remains important because of the mortality that it causes. It can be fatal. That is why becomes important. In the chronic kidney disease, all the cases are renal only. All the cases are renal only. There is no pre-renal, post-renal in CKD. They are all renal only. So they are classified based on whether they are acquired causes or inherited causes. Among the acquired causes and the most common cause in the world, there is the topic of diabetic nephropathy. And among the inherited causes, we want to discuss 2 conditions: Alport's syndrome and adult polycystic kidney disease. Under the inherited causes, we want to discuss 2 syndromes: Alport's syndrome and adult polycystic kidney disease. And at the end of the nephrology class is the topic of renal replacement therapy. is the topic of renal replacement therapy, which includes both transplant and dialysis. We need to identify. So simple here. So what we have to check here, acute versus chronic kidney disease is what we are covering in this lecture. So in this session we know when the patient comes with symptoms of renal disease, first you do the screening test. If the screening test is positive, you ask them to undergo urine analysis, ultrasound and estimate the GFR, based on which you get a lot of clues about the diagnosis. But before you go into the detail, first step what you do, you decide whether it is acute or chronic. If it is acute kidney disease, the parameters are non-specific. So for the diagnosis you need to take the help of KD-IGO criteria. But in the chronic kidney disease, ideally you need to have a 3-month medical record. But even if you don't have, there are few parameters, findings which can be specific of the disease, which can be used for direct diagnosis of this condition. And as I told you, why is this important? Because the treatment and further evaluation is different. In an acute disease, you want to admit the patient, search for the cause and treat rapidly. In chronic kidney disease, unless there is a serious problem, you can manage them on outpatient department. Please remember, in CKD, the problem is either diabetic nephropathy and many other acquired ones, or it is inherited causes, Alport's and adult polycystic kidney disease. So I have made a separate video for the CKD and diabetic nephropathy, separate video for inherited causes of CKD. But before we go there, let's focus on the acute kidney injury. Acute kidney injury. In this session, we are going to discuss the pre-renal, the post-renal causes and indications for RRT. In the next lecture, in the separate video, I have covered the topic of renal ACII. And of course, needless to say, separate lecture for renal replacement therapy. So in this lecture, we will focus on further approach to ACII till we reach the diagnosis of renal, and then we will take a break, cut it here and go on to the next video, which is consisting of only renal ACII alone, right? So the classification is here. The complete topic of nephrology is summarized in front of you. Let's take it one by one. So what are the typical, how do you approach a patient with ACII? So I have taken the next step now. I hope you are noticing. We started this session with approach to renal disorder. Now we have fine-tuned our approach to a case of acute kidney injury. We have fine-tuned our approach to a patient of acute kidney injury, which is diagnosed using KD-IGO guideline approved, confirmed, KD-IGO criteria confirmed. So you know that the patient is a case of acute kidney injury. What to do further? You have reached till here that it is an acute kidney injury, but treatment depends on where is disease, what is disease, you still don't know. You just know the presentation that it is acute. So the first step in a patient with acute kidney disease, is to look at the collecting system defect, on the ultrasound. Collecting system defect on the ultrasound is the first thing to see. in a patient of acute kidney injury. Why? Suppose the collecting system is abnormal. What can you confirm? This is a case of post-renal AKI. You can confirm the diagnosis that this is a patient of post-renal AKI. And you must know post-renal AKI is treated by urologist, not a nephrologist. ये क्या हो गया? Surgical branch. Refer to surgery. If the problem is calculus, hydronephrosis, refer to surgery, not your problem. Post-renal AKI. But is it common? No. Only 1 to 5% will be positive. Once you say that the collecting system is normal, if you say collecting system is normal, what are we doing? Excluding the post-renal cause. When the collecting system is normal, you are excluding the post-renal cause. So what differential diagnosis remains with you after excluding post-renal? The possibilities are you are dealing with a pre-renal AKI. I am going to use the same colors throughout the nephrology session so you can help correlate better. Or we are going to have a renal AKI, or the patient is suffering from a case of renal AKI. So in this approach table, our point is to differentiate whether it is pre-renal, renal or post-renal. The first step, post-renal, either confirm or exclude, either confirm or exclude. So what remains with me is the choice between pre-renal and renal cause of AKI. Now this is one of the most important questions both in practice and MCQ, how to differentiate between the two. How to differentiate between the two, pre-renal and renal AKI. Rather than jumping to the parameters, let us make a quick point about the pathophysiology of the two. Rather than directly writing parameters, let me take the opportunity to write a little brief pathophysiology of the two. That itself will highlight that they are different from each other. In pre-renal, the problem is renal hypoperfusion. Hypoperfusion, what does it cause? RAS activation. What does it cause? RAS activation it's going to cause. And we know RAS activation causes increased sodium and also increased urea reabsorption from the tubule. So the kidney gets the signal that you have to reabsorb maximum water because renal perfusion is less. So kidney gets the message to maximize the water absorption. As discussed along with channelopathies, water absorption is linked mainly to the sodium. It is also linked to other solutes with a positive osmotic potential. Other solutes which have a positive osmotic potential like urea are also absorbed by the kidney to facilitate more water reabsorption. To facilitate more water reabsorption. In the renal AKI, remember 95% are tubulo-interstitial. That means they have loss of concentrating ability. Due to loss of concentrating ability, there is increased sodium loss in the urine. Opposite, no? In the pre-renal, sodium is reabsorbed from the urine. In the renal, sodium is lost in the urine. So now you know, pathologically they are totally different entity. So based on that, you can create the differentiation table. You can use urea divided by creatinine ratio. The urea divided by creatinine ratio, which is normally less than 12:1, which is normally less than 12:1. You can take into account the urine osmolarity. You can take into account the urinary sodium level. Take into account the urinary sodium level. And you can also consider the point of FeNA. FeNA, fractional excretion of sodium in the urine, is the most sensitive marker. MCQ, it is the most sensitive parameter. Fractional excretion of sodium in the urine is the most sensitive parameter to differentiate between the prerenal and renal cause of AKI. Tell me how to fill this table. Let's start at the top. This urea create ratio needs to be understood. We all know that when the urea create ratio is high, it indicates prerenal. But today I want you to know why, not just high. Why? Because in prerenal, why the urea rises more, while in renal the rise is proportionate. So look at it carefully. Whether it is prerenal or renal, there is a drop in the GFR. Yes, there is a drop in the GFR. Let us say the patient has 20% reduction in the GFR, because of which there will be 20% decrease in the excretion of both solute, urea also, creatinine also. So in the blood, in the serum, there will be rise in urea, rise in creatinine. But how much will be the rise? 20% each. 20% यूरिया भी बढ़ेगा, 20% क्रिएटिनिन भी बढ़ेगा. तो डिवाइड करोगे तो क्या होगा? रेशियो रिमेन्स unchanged. 20% cancel each other. So the ratio remains normal, less than 12:1, because what is there? There is a proportional. There is a proportional rise in both the solute. Both the solute, which is proportional to the decrease in the GFR. So the rise is proportional. Urea also 20% बढ़ गया, creat also 20% बढ़ गया. So if you divide the 20 off, then you get a proportional value. So ratio remains normal in renal AKI. But what happens in pre-renal? Same principle, 20% तो दोनों बढ़ गए. But along with the 20% increase of the solute, there is increase of urea by another mechanism also. So excretion is hampered and reabsorption is increased. So the ratio को क्या हो जाता है? Ratio double rate से बढ़ रहा है, more than 20:1, because there is a disproportionate. There is a disproportionate rise in the urea level. Urea level due to drop in the GFR also, and due to increase in the reabsorption also. So urea level rises more than the creatinine. Rise in creatinine level is only related to GFR. So creatinine remains little high, but urea becomes very high, because not only excretion problem, there is reabsorption also. I hope this is clear. So elevated urea creat ratio indicates pre-renal. Yes, correct answer. What about urine osmolarity? Urine osmolarity remains concentrated. Urine osmolarity is concentrated because all the water, sodium is reabsorbed. Sodium is reabsorbed. So urine sodium content will become less than 20 milliequivalent. So excretion of sodium in the urine will be less than 1%. So FeNA less than 1% indicates pre-renal. But if the patient has urine osmolarity more less than 350, dilute polyuria, urine osmolarity, sodium is lost, water is also gone, less than 350 milliosmol per liter, but the sodium is lost in the urine, so sodium is more than 40 milliequivalent. FeNA is minimum 2%. FeNA will be minimum 2% in case of renal AKI. So very important chart this is. So patient has come to me with a acute kidney injury. In a patient with acute kidney injury, what did I do first? I first either confirmed that it is post-renal, and if it is, I referred to surgery. But if it is normal, I excluded post-renal, and then I differentiated between whether it is pre-renal or renal using the urea creat ratio, urine osmolarity, urinary sodium and FeNA level. So FeNA is most sensitive but not the most specific. So MCQ wants to know what is the most specific parameter. What is the most specific parameter to differentiate between the two? सेंसिटिव तो ठीक है, बट मुझे एक्यूरेसी भी तो चाहिए. What is the most specific parameter to differentiate between the two? So the answer lies in, there are few novel markers of AKI. There are few novel markers of acute kidney injury. There are few novel markers of acute kidney injury. They are there. Novel markers of acute kidney injury. These markers are secreted by the tubule. They are secreted by the tubules into the urine. By the tubules into the urine in response to injury. In response to injury, they are secreted by the tubules into the urine in response to injury. These markers are there which are secreted into the urine. But when the tubules, matlab kidney, tubules are injured, when the tubules are injured. So where we can test? We are testing, they are tested in a spot urine sample. They are tested in a spot urine sample, and if they are positive, it indicates, what does it indicate? Renal cause of AKI, that is same as nephropathy. So you are going to check for the spot urine sample. You are going to check for whether the patient has the novel marker present. If present, then definitely problem is in tubule. Tubule matlab renal, matlab nephropathy. So if the novel markers are absent, there is undetectable markers. Undetectable markers favors diagnosis of pre-renal, but detectable markers are specific for renal cause of AKI. Specific for the renal cause of AKI. So which are the markers? Markers are couple of them. Which are the markers? The most studied marker is the NGAL, the neutrophil gelatinase, associated lipocalin. We have got KIM1, kidney injury molecule. We have got KIM1, kidney injury molecule. We have got interleukin 18. We have got interleukin 18. Interleukin 18. All these markers can be checked in a spot urine sample. If they are present, they are diagnostic of renal AKI. But among the approved markers, we have only two. We have got a tissue inhibitor of metalloproteinase 2. Tissue inhibitor of metalloproteinase 2. Tissue inhibitor of the metalloproteinase 2 is present, and we have got the insulin like growth factor binding protein 7. Insulin like growth factor, insulin like growth factor binding protein 7. Binding protein 7. This binding protein 7, only these two are the approved markers. These are the only two approved markers for commercial use. Approved markers for commercial use. But of course, India अलग country है. India में before TI-MP has come, urinary NGAL, urinary KIM1 tests are available, kits are available. So, but theoretically speaking, only there are two approved markers for commercial use, that is the TI-MP2 and the IGF-BP7 for diagnosis of renal AKI. Diagnosis of the renal AKI. So, get this clarity done. So, how can I confirm that the patient has renal AKI? When the marker is positive. Marker is positive. I know that it is renal AKI. So, diagnosis is confirmed now, whether the problem is post-renal, whether it is pre-renal, or whether it is a renal cause of AKI is already confirmed. Whether it is post-renal, whether it is pre-renal or renal is confirmed. So, let us complete the treatment of AKI in this session. So, how will you treat management of AKI? Let us address the very important management of acute kidney injury. Let's continue. Acute kidney injury, like I have been telling you repeatedly, depends on the severity of the presentation. Depends on the severity of the presentation. So, we can divide them into two groups. Divide them into two groups. Acute kidney injury presents in emergency. Presents in a emergency. Presents in a emergency. What does it become? It becomes an indication for urgent dialysis. Indication for dialysis. In short, it becomes an indication for renal replacement therapy in acute kidney injury. So, very logical, it's very logical that when a patient of acute kidney injury comes in an emergency, I don't have time to search for the cause and reverse the cause. First point is to save the patient. So, I start on dialysis, parallelly I investigate the cause and treat the cause. But if it is not an emergency, if the patient is stable, you can proceed with the specific treatment of the underlying cause. You can proceed with the specific treatment of the underlying cause. That is the approach, simple approach. दिस इज जस्ट प्लेन कॉमन सेंस, है ना. इमेजिन आग लगी है ना, आग सामने कहीं लगी है एम्प्टी कंपाउंड में, तो रुक जाएंगे हम लोग, है ना, आराम से बुलाएंगे कहाँ से आग लगी ये सब सोचेंगे. बट आग अपने घर पे लगी तो पहले बुझाएंगे ना, उसके बाद सोचेंगे कहाँ से लगी. सो सिमिलरली इमरजेंसी में ढूंढना नहीं व्हाट इज द प्रॉब्लम, पहले सेव करो, बट स्टेबल होगा तो ढूंढेंगे ना. विल सर्च फॉर द कॉज एंड ट्रीट द अंडरलाइंग डिजीज. सो व्हाट आर द इमरजेंसी indications for dialysis in a patient of AKI? MCQ. Number 1 indication, presence of serious uremic manifestation. Number 1 MCQ. Go back to your symptomatology. Which are the serious uremic features? Serious uremic feature include encephalopathy, convulsion, pericarditis and shock, and coagulopathy. These are the 5 life threatening uremic features. We have written them down. Number 2, if the patient comes with severe azotemia, that is urea level more than 100. So uremic complications might not have occurred, but the levels are high enough for it to occur. So you don't wait for them, aane de convulsion, don't wait for them to deteriorate to offer dialysis. Severe azotemia is an indication for dialysis. If the patient has refractory fluid overload state, that is pulmonary edema. So if the patient is having anuria, the patient is having fluid overload, and if it causes pulmonary edema, it is a complication. Refractory means what? Refractory means unresponsive to first line therapy, and that is IV loop diuretics. So if the patient is not passing urine and going into fluid overload, I am going to push Lasix, furosemide. But if the urine does not come, then my choice will be to go for dialysis support. Number 4, if the patient has refractory metabolic acidosis. Patient has refractory metabolic acidosis. The word refractory means unresponsive to first line therapy. First line therapy is IV soda bicarbonate infusion. So I started the patient on soda bicarbonate infusion, but even after that the pH remains less than 7.20. Number 5, if the patient has refractory hyperkalemia. If the patient has refractory hyperkalemia, can go into life threatening arrhythmias. Refractory hyperkalemia means unresponsive to what? Glucose insulin drip. Unresponsive to glucose insulin drip, then that means it is refractory case. And number 6 indications, specific indications are there. When the patient has ingested dialysable toxin, consumed dialysable toxin, then you go for dialysis. What are the examples of dialysable toxins? We have got methanol, we have got salicylate, methanol, salicylate, we have got polyethylene glycol, lithium, polyethylene glycol and lithium, which are considered dialysable toxins. The common dialysable toxins in the world they are. So patient of acute kidney injury comes to your clinic, you will admit the patient, If the patient has any one or more of these life-threatening manifestation, what is your first treatment? Dialysis. First step is to do dialysis. Then you evaluate for underlying cause and start the appropriate treatment. But if none of these parameters are there, what we will say? Patient is stable. ठीक है? So we approached the patient, reached the diagnosis. What was the diagnosis? A. The patient could be a case of post-renal ACII. The patient could be a case of post-renal ACII. What should you do? Prompt surgical relief of obstruction. Prompt surgical relief of obstruction is associated with excellent recovery and excellent prognosis. Because what we studied, collecting system is only a physical conduit. Obstruction था, खोल दिया, kidney function returns to normal. Kidney function returns to normal. Excellent recovery. But what if the patient was having pre-renal ACII? What if the patient was having the pre-renal ACII? Patient was suffering from the pre-renal ACII. Let us see here. If the patient was suffering from the pre-renal ACII, let us see here. Patient was suffering from B, the pre-renal ACII. Pre-renal ACII, remember the causes? Hypovolumic shock, cardiogenic shock, septicemic shock, and drugs disrupting autoregulation. So how I can reverse? IV fluid is the first line of treatment. If it does not work, I am going to start the patient on inotrope support, broad spectrum antibiotics. I am going to also stop the offending drug if any. Stop the offending drug if any. And still what I will get in return? Excellent recovery. I am going to get excellent recovery. मतलब क्या? ये भी बच गया साला. So post renal 1 to 5%, pre-renal 85% patients have recovered and gone home. Means 90% of acute kidney injury घर चले गए, तो अपना घर कैसा चलेगा, है ना? So for that only we have got the number C, renal ACII. We have got the renal ACII, which is not common but important. It requires further evaluation to plan the management. Requires further evaluation to plan the management, right? So the separate video we will make on the renal ACII. So let us review this chapter that we did just now. We are completed approach to renal disorders. So first step I classify that it is acute or chronic. If it is acute, I had to approach it further and identify whether it is pre-renal or post-renal. Both topics I have completed till the prognosis of each. If it is renal, I require further evaluation. This is where we are. So in the next video, we are going to discuss the renal ACII. And then in the subsequent videos, of course, we are going to discuss CKD with diabetic nephropathy, inherited causes of the CKD, and renal replacement therapy. And at the end, don't miss a complete review of nephrology using images, right? So let's continue forward.